Hey doctors, Greg Friedman here. Going to give you a little brief explanation of the new 2021 E&M code rules. Broken this down, and once you understand it, it's pretty easy. A couple of things to start off with, though, is a number of you were kind of messing up in the past on these E&M codes, thinking that when you do an exam, that if you spend 30 minutes on the exam, that would count as a 99203, for example. Well, that's not correct. The time component of the old E&M codes only came into play when you were doing counseling and coordination of care that was taking up at least 50% of your face-to-face time with the patient, which was usually not what we were doing as chiropractors. I mean, sometimes, but not very often. So that was a mistake that a lot of chiropractors are making. But now for 2021, beginning January 1st, which is already passed, they're trying to make this easier for us. Now, keep in mind that these E&M codes were not designed with chiropractors in mind at all, ever. These are medical codes. This is where medical doctors get paid. This is where primary care doctors get paid. This is their number one source of revenue. Not so for chiropractors. We build this on the initial exam and maybe some re-exams. It's a very small part of our revenue stream. But we have to know how to do this properly. So they tell us that for 2021, the E&M codes could be decided by either using time or what's called medical decision making. All right, so let's start with time. So I have a little chart up here. So first of all, understand that the code 99201 has been eliminated. That's gone completely. All right, so that leaves us for a new patient, which is defined as a patient that you've either never seen before or it's been more than 3 years since you last saw them, right? That is a new patient. An established patient is one that you have seen within the last 3 years. All right, so for the new patient, the codes are 99202 through 99205. All right, so as you can see from the chart here, if you just go right over to it says history and exam, all they tell us is medically appropriate history and or exam. All right, so they're not being specific about that. They don't really care much about that. However, we still have to do a medically appropriate history and exam. So don't think you're going to get away without doing that. You have to do that. You're a doctor anyway, damn it. Do the damn exam. All right, go over to the right side and you'll see total minutes. So 99202 is 15 to 29 minutes. 99203 is 30 to 44 minutes. 99204 is 45 to 59 minutes, and the 99205 is 60 to 74 minutes. Okay, so now we go to the chart below that, and that's for the established patient, and that includes 99212 and through 99215. Now, I did add in there 99211 because although it wasn't eliminated, it doesn't have anything to do with the time or medical decision making. A 99201 is simply like the doctor doesn't even have to be there. It's defined as a problem that may not require the presence of the physician or other qualified health professional, but the service is provided under the physician's or other qualified health professionals' supervision. So in the medical office, this would be one of the staff, non-doctor staff, doing vital signs for a patient, or maybe a medical assistant doing vital signs. Doctor's not doing it. This is usually not done in a chiropractic office. All right, so some of you have been using this code to undercode for a re-exam to try to save your cash-paying patient money. That is inappropriate. All right, don't do that. So that's the definition for that code. Then you've got 99212 through 99215. And again, if you look at the right side, the minutes, you've got for 99212, 10 to 19 minutes, 99213, 20 to 29 minutes, 99214, 30 to 39 minutes, 99215, 40 to 54 minutes. Okay, so now the question is, so what's included in that time? What do we do for that? Well, here's the thing. Ideally, we should be documenting time in and time out, as well as the total number of minutes spent on that exam. And the reason for time in and time out is just in case some reviewer or auditor is trying to challenge you. That time in and time out could be very helpful to you. So that's a good thing to do. Here's the cool thing about this though. So it used to be for the timing part, just the face-to-face part of the counseling coordination of care. But with these are the things that are included with the time. All right, preparing to see the patient, like reviewing of tests, obtaining and or reviewing separately obtained history, performing a medically appropriate history and or exam, there's your history and exam, counseling and educating the patient, family, or caregiver, right? Ordering test or procedures. So if you're going to order x-rays or other tests, the time that it takes you is included in this time. Referring and communicating with other healthcare professionals when not separately reported. So if you're having to refer out to another doctor or call another doctor to refer your patient to, that is also included in the time, right? Documenting clinical information in the electronic health or medical record. So if you're using EHR or EMR, the time it takes you, not your staff, but you to enter that information into the software counts. Independently interpreting results not separately reported and communicating results to the patient, family, or caregiver. And finally, care coordination, which is not separately reported. All right, I put in bold the 4 items that most chiropractors will utilize on every new patient exam, and that would be obtaining and or reviewing separately obtained history, okay? Number 2, performing a medically appropriate history and exam. Number 3, counseling and educating the patient, family, caregiver. And number 4, documenting clinical information in the EMR or EHR, all right? So those 4 things could be automatic. Unless you're not using an EMR, EHR, then you wouldn't use that one, or if you're not doing the other things. And then the other things that are not in bold, you should add those as appropriate, all right? So when we do this, you can see that, I'll go back up to the time for a second. For a new patient, spending 30 minutes on all that for a new patient, which is certainly doable with all that stuff that we're doing, that would be a 99203. Now, I caution you, if you think that you're going to do a stupid, crazy exam on an uncomplicated type of a case, and you're going to spend 45 minutes to an hour on it so that you could bill a 99204, 99205, don't do it, all right? I think we're going to be able to smell that a mile away, and it's going to be a problem because according to CMS, if you are upcoding for the purposes of getting better reimbursement, that's considered not abuse, but fraud, and that's a bad thing, all right? So don't be trying to tell us that you're spending all this crazy amount of time with it. Be reasonable, but I think 30 minutes to do all that on a typical new patient of ours, I think that's doable on a lot of our patients. There's going to be a number that'll be a 99202 if they're pretty uncomplicated, but I think the fair amount will be 99203. And as far as the re-exam on that, like a 99212, you don't need to do the whole ortho-neuro exam over again, especially if there were normal stuff before. Unless something changed, you would simply need to do what was previously abnormal. That just takes a few minutes. So you're probably going to be more in the 99212 zone for the re-exam, but it's possible you could be in the 99213. 99214, again, possible, but not very likely. These are going to be the more complicated types of cases where you've got some radicular issues and maybe some other comorbidities. Okay, now let's look at the other factor, which is medical decision-making, all right? Now, this one is great for medical doctors because when they have got to go through a bunch of other records and looking at all this other stuff, this might be better for them than the time. They may not be using as much time, so the medical decision-making for them might get them to a more appropriate code that could be higher. But for chiropractors, let's take a look at this. So again, 992, well, first of all, there's 3 factors here. Number 1 is the number and complexity of problems addressed. Number 2 is amount and or complexity of data to be reviewed and analyzed. And number 3 is risk of complications and or morbidity or mortality of patient management. All right, so remember, I already talked about the 99211. All right, so Probably not going to be using that anyway. 99202, 99212, all right? That's considered a straightforward level of medical decision making, all right? So you need at least 2 out of these 3 components between the number and complexity of problems addressed, the amount and or complexity of data to be reviewed and analyzed, and the risk of complications. All right, you need at least 2 out of those 3 to qualify for any of these categories. All right, so for a 99202, 99212, all right, first of all, number and complexity of problems addressed is minimal. That means 1 self-limited or minor problem. Now, some of you are thinking, well, that's easy because, I'm treating a patient for neck pain and upper back pain and middle back pain and lower back pain and all that. That's 4 different problems. No, that's not how they're counting it. They would count that as 1. Spine, 1 problem. Yeah, so don't get excited about that. So that would be minimal, 1 self-limited or minor problem. All right, and then we get to the amount and or complexity of data to be reviewed and analyzed. Now look at this. The asterisk says each unique test, order, or document contributes to the combination of 2 or combination of 3 in category 1 below. All right, so if your patient comes in and you're not looking at other records and they didn't bring in other information from previous doctors and there's no test you're looking at right now, which is a lot of the patients that we see, that's going to be minimal or none. And number 3, risk of complications, morbidity, mortality is going to be minimal from additional diagnostic testing or treatment, which kind of defines many of the new patients that we're going to see. So you're seeing so far that a lot of our new patients could fall into that 99202, 99212 when dealing with the medical decision-making component. So how do we get to the 99203, 99213? Okay, let's look at this. This would be a low level of medical decision-making, which is 1 level higher than straightforward. All right, so low means that there are 2 or more self-limited or minor problems, or 1 stable chronic illness, or 1 acute uncomplicated illness or injury. Okay, so the typical patient that we see as chiropractors is most likely going to fall under that 1 acute uncomplicated illness or injury. Again, even if you're doing neck, upper back, middle back, lower back, right shoulder, left shoulder, I'm concerned that not only do they count spine as 1, I wonder if they're going to count musculoskeletal as 1. I'm going to assume that for now anyway. So anyway, we can fall into 99203, 99213 with 1 acute uncomplicated illness or injury. Now, before you think that chronic lower back pain is considered a stable chronic illness, it's not. They're thinking about chronic kidney disease, hypertension, stuff like that. All right. 2 or more self-limited or minor problems. Maybe if they're not counting musculoskeletal as 1, we could say anything related to the spine is 1 and maybe an extremity is the 2nd one. Not sure about that yet. So anyway, the number and complexity of problems addressed, we could fit into 99203, 99213. But here's where it gets a little dicey. All right, the amount and or complexity of data to be reviewed and analyzed. All right, now remember, we need a combination of 2, at least 2, well, let's see what it says. Limited, must meet the requirements of at least 1 of the 2 categories. The 2 categories are tests and documents and assessment requiring an independent historian. All right, well, most of us are not going to be dealing with an assessment requiring an independent historian. Now, that could be if the patient needs a translator or a sign language or something like that. But without that, we're probably not going to be there. All right, so let's look at category 1, tests and documents. Any combination of 2 from the following. Review of, now this is on the date of the exam. Review of prior external notes from each unique source. Review of the results of each unique test, and ordering of each unique test. Okay, so if you order x-rays or labs on that exam visit, okay, that's 1. What do we do for the second one? We need a second one in there to qualify for this. All right, so unless that patient comes in with prior records or you get a hold of those records that you're looking at, that's going to be a little challenging. And then at the right side, we see there's a low risk of morbidity from additional diagnostic testing or treatment. Now, we would consider, well, yeah, what we do is low morbidity, low risk of death. Well, actually, what we do is typically minimal risk of morbidity. So remember, minimal is lower than low risk. So you see what's happening here? Now, to get to a 99204, 99214, it gets even more challenging here. So this becomes a moderate level of medical decision making. You've got one or more chronic illnesses with exacerbation, progression, or side effects of treatment, right? Or two or more stable chronic illnesses, or one undiagnosed new problem with uncertain prognosis, or one acute illness with systemic symptoms, or one acute complicated injury. Now, this could be somebody who comes into us and they've got fractures and herniated disc maybe, things like that. That might help qualify for that. Well, once again, though, then you get to the second column here, the amount and/or complexity of data to be reviewed and analyzed, and it's moderate. Must meet the requirements of at least one out of three categories, right? One out of the three categories. The three categories are any combination, well, category one is test documents or independent historians. Number two is independent interpretation of tests. Number three, discussion of management or test interpretation. All right, first, test documents or independent historians. You need any combination of three of the following four. Review of prior external notes from each unique source. Review of the results of each unique test. Ordering of each unique test. Assessment requiring independent historian. You need three out of the four. Or an independent interpretation of a test performed by another physician, other qualified health professional, not separately reported. Or discussion of management or test interpretation. Okay, you can see that that's going to be a little bit more complicated. And then we get to the third column, which gives us a moderate risk of morbidity from additional diagnostic testing or treatment. All right. Examples would be prescription drug management, which most of us don't do, or discussion regarding minor surgery with identified patient or procedure risk factors, not something most of us do. Decision regarding elective major surgery without identified patient or procedure risk factors, not really in our wheelhouse. And number four, diagnosis or treatment is significantly limited by social determinants of health. As you can see, this becomes difficult. That's what I'm saying, doctors. When you start using these, and you any patients since January 1st should be using these now, it is going to be way easier for us to get into that category of, let's say, 99203, 99213 with time. All right, it's going to be way easier to do that, but you've got to document that time. So now I'm going to show you how I document that. Okay, so I'm going to do this in my EMR. All right, so first I'm going to document, all the stuff that's going on, whatever symptom. In this case, it's just right-sided neck pain and all that. Now I go to the exam, and here's what I'm going to do. All right, the first thing I'm going to do is decide, am I going to do this based on time or medical decision-making? I already should have an idea. If there's a shit ton of records that I've got to look at and test and all that, then I might use decision making. Otherwise, I'm just going with the time. And then I want to select, is this a new patient or an existing patient? All right, so let's say it's a new patient. All right, now I want to document time in and time out. So let's say where I am right now, it is 2:30 in the afternoon. All right, so 2:30. And make sure you get AM and PM right. All right, and let's say I finished up at 3:03 p.m. All right, now my EMR, once I put the time in and time out, I have a program so that it already calculates for me the specific number of minutes. All right, and now what I've done as I go down a little bit, my program actually eliminates or it deactivates the established patient codes because I said it was a new patient. So I'm only looking at the new patient codes, 99202 through 99205. And I already had it programmed so that whatever the total time is in minutes, bam, I've got it for the right code, which is 99203, which is 30 to 44 minutes. Now, those other things I showed you, like I default automatically to these things, obtaining and or reviewing separately, obtain history, and so on. It's already checked off for me. If I need to deselect something or add something, I certainly could do that, but at least I've got that. So doctors, that's how we can do that really quickly. And then, of course, what I'm going to do is start doing my actual exam and documenting from there. Well, let me I'll show you what this looks like in my SOAP note. Okay, so this is what it would look like in my actual SOAP note. So under the orthoneuro exam, I'll read it for you. It says, an evaluation, CPT code 99203, was performed on this patient today using time as a determining factor. 33 minutes were spent obtaining and or reviewing separately obtained history, performing a medically appropriate history and or examination, counseling and educating the patient family caregiver, documenting clinical information in electronic health record or medical record. The exam consisted of, and then I would go ahead and document what I did in the exam and both positive and negative findings. So that is a nice, quick, and easy way that we can do it. So again, to recap, I really think that for most of us, for most of our patients, for most of our exams, time will be the factor that's going to be easiest for us to use to get us to where we want to be. The medical decision making is going to be if you're seeing a lot of really complicated cases and you've got a lot of other records to look at, and you're doing a bunch of other tests and referring out for other tests and referrals and all that, then you might be into the medical decision making. But again, that's going to be less common than for the time. All right, I hope that helps. You guys have any questions, feel free and give me a shout.